All right, I'm going to go over some of the biggest maternal complications after birth. So, probably the biggest one is postpartum hemorrhage. That's our first one. This is an emergency. It is the leading maternal complication, and the cause is often due to uterine atony, which is just when the uterus is not contracting. After mom has the baby, we want for the uterus to contract back to its normal size. If it doesn't, it leads to uterine atony, which then leads to postpartum hemorrhage. It can occur rapidly, and it may not always be obvious right away. So we want to make sure we're doing a good admission assessment, getting a good baseline for the patient. Also remembering that this is traumatic for the patient, so we want to stay calm and reassure them, make them feel safe, and thinking about the support person as well, making sure that there's someone there to support them, tell them what's going on, what we're doing for mom, and how we're going to help them. So there's kind of two categories for when it can happen. Early is within 24 hours, and this one is sudden and severe. Late can happen up to 16 weeks later. That one's usually due to infection or some sort of delayed healing process. So main risk factors are going to be multipara, so multiple children, large baby, because it can cause like birth trauma and things like that, and then previous postpartum hemorrhage. There are 4 main causes, the 4 T's. So tone is the number one. This is uterine atony. It's the most common cause, and it's when the uterus fails to contract. And then the next one we have is tissue. So this can be like retained placenta or like placental fragments in the uterus. This is going to prevent the uterus from contracting properly. So intervention for that's typically they're going to have to do a sweep. If the patient's getting a sweep, you want to give them pain meds very quickly, because when they do a sweep, it's doctors going in up to their elbows into the uterus and sweeping out all of the clots and things like that. And then if the sweep does not work, they may have to do a D&C. So then next one after that would be trauma. So things like lacerations, and these can be of the birth canal, perineum, or vagina, or there can also be hematomas, which can be vulvar, vaginal, or retroperitoneal. This can happen due to things like large baby and birth trauma. If the patient is bleeding despite a firm fundus, we want to suspect that this is a laceration. And so whenever it's a laceration, and we'll go through the meds and the interventions in a second, but what you're going to want to do is you're going to do TXA versus the, you wouldn't really want to do the uterotonics. You would want to do the TXA so that the blood can clot and they can stop bleeding. And then last one is thrombolytin. This is going to be if the patient has a clotting problem, and that's usually caused by bleeding disorders like von Willebrand or IVP, which is immune thrombocytopenic purpura. And would also give TXA for that as well to help with clotting. So our interventions. So the first intervention we're going to do is a massage. That one is very, very important to help get the fundus firm. And then also we're thinking about, is the bladder empty? The full bladder can inhibit the uterus from contracting properly, and it can also displace it, so we don't want to do, so we want to make sure that it's empty. If it is not, we can get the patient up to pee if it's safe to do so, or we can also try to do a straight cath. Second intervention is going to be our medications, which are going to be the uterotonics and or anti-fibrolytic agents. That anti-fibrolytic agent is the TXA I was talking about. And typically, if patient is having postpartum hemorrhage, because it is such a big emergency, they're going to use the kitchen sink approach and kind of just throw a whole bunch of meds in it and see what works. And then depending on the situation and severity, there are options if needed. So you can do the sweep, There's the DNC. There is the balloon. It's put into the uterus and it inflates. This one is used less often by the hospitals now. At hospitals now, they use the Jada most of the time. And that one, instead of inflating, it actually suction cups and it's inside the uterus and it pulls clots out. It's left for 2 hours and then they turn the suction off, and if bleeding stops, they're able to remove it. And then if they're having a super severe hemorrhage, they could possibly end up having an emergency hysterectomy. So medications, we could do oxytocin, which is a uterotonic. That one's going to be IV. Metrogen is IM, but it is contraindicated in hypertension. It increases BP. This one's also a uterotonic, but we cannot give it if they have hypertension. And then hemobate, also IM, but contraindicated with a history of asthma. It can cause bronchoconstriction. And it's a uterotonic too. So you want to kind of think about these things, and that's why you want to know your patient's history and stuff. It also has a side effect. The hemobate has a side effect of explosive diarrhea. So we want to warn the patient of that potential side effect and also give an anti-diarrheal if we're giving this to them. The Cytotec can be given orally, or it can also be given rectally if the patient's got no access, and it's a uterotonic. And then we've talked about TXA a little bit. It's an anti-fibrolytic agent. That one's given if there's like a laceration suspected or if blood clotting disorder, and this helps clots form.